Let's pivot now. We're shifting from orthopedic precision to a major public health initiative where your role as a GP is absolutely pivotal, the National Lung Cancer Screening Program. Lung cancer. It's still the leading cause of cancer death, isn't it?
Unfortunately, yes. It remains the leading cause of cancer death in Australia, which really underscores the immense importance of programs like this national screening initiative.
And your role in this isn't just important, it feels absolutely central to its success.
Yeah.
You're the first point of contact, the gatekeeper who identifies and guides eligible patients through it.
That's exactly right. The GP is central.
So for a busy GP listening, what are the crystal clear specifics? Who exactly is the target population for this program? Let's nail this down.
Okay, this is key. The program targets individuals aged 50 to 70 years. Crucially, they must be asymptomatic, so no signs or symptoms of lung cancer.
No cough, no weight loss, nothing suspicious.
Correct. They need to be current smokers or have quit within the last 10 years, and they must have a smoking history of at least 30 pack years.
Okay, 50, 70, asymptomatic, current or recent quitter within 10 years, and 30 plus pack years. Now that 30 pack years calculation, it can sometimes be a bit of an imperfect science in a busy clinic, can't it? What's the advice there?
You're right. The guidelines themselves acknowledge it's an imperfect science. The advice is to use your best clinical judgment and estimates based on the patient's history.
Okay.
But here's a helpful point. Once that smoking history eligibility is confirmed, it doesn't need to be reassessed for their continued participation in the program. That simplifies follow-up quite a bit.
Good to know. And how is the screening actually done? And what about cost? That's always a huge concern for patients, especially with new programs.
So the program uses free low-dose computed tomography scans, LDCT scans.
Low-dose CT.
Yep. Scans are provided every 2 years, generally, unless a screen-detected abnormality means they need a shorter interval scan. And here's the really excellent news for patients regarding cost. There are 2 specific Medicare benefits schedule item numbers.
MBS items.
Yes, 574NA for the standard 2-yearly scans and 57413 for any interval scans. Both require mandatory bulk billing.
Mandatory bulk billing.
Correct, which means 0 out-of-pocket cost for the scan itself for the patient. It removes a significant financial barrier.
That's fantastic. Huge. So beyond just identifying patients and getting them the scan, what are the GP's core responsibilities throughout the program? It sounds like it's more of a continuing partnership.
It absolutely is a partnership. Your role is really multifaceted. You promote the program within your practice, you identify those eligible patients, and critically, you assess and confirm their eligibility and suitability for the LDCT scan before each request. It's not just a one-off check.
Okay, suitability check each time.
Yes. And shared decision-making is vital here. You must discuss both the benefits, potential early detection, and the potential harms of screening with your patient.
Harms like?
False positives, anxiety, potential for investigating benign nodules, radiation exposure, though it is low dose. They need to make a properly informed choice.
Right. Makes sense. And the admin side, like enrollment, does the GP handle that?
Yes. You enroll participants in the National Cancer Screening Register, the NCSR, or you can delegate this task within the practice. The NCSR acts as a crucial safety net, providing program info and sending reminders to both patient and GP.
Okay.
When you request the LDCT scan, you use either a program-specific form or your usual practice form, but make sure you clearly specify it's for the NLCSP and include all the relevant history.
Got it. And smoking cessation. Obviously a huge, continuous part of this picture. Do patients actually have to quit smoking to participate in the screening?
That's a very important distinction to make clear to patients, and the answer is no. They do not have to quit smoking to participate.
Okay, that's critical.
Absolutely. However, you should definitely take the opportunity at every relevant encounter to offer smoking cessation support. Use the Ask, Advise, Help brief intervention model.
Ask, advise, help.
Yeah. And it's crucial this is done in a non-judgmental, empathetic manner. We know there's often high stigma associated with tobacco use, so sensitivity is key.
Absolutely. So once the results come back, what's the GP's role in communicating those and figuring out next steps?
You're responsible for communicating those scan results to the participant. It needs to be timely, precise, and sensitive. The NCSR will also notify both you and the participant when results are available, which is helpful.
Okay. And if something concerning is found?
If there are high or very high risk findings suggesting cancer, your role is to refer that participant promptly to a respiratory physician or a specialist who is linked to a lung cancer multidisciplinary team, an MDT.
Right.
That further investigation happens outside the scope of the screening program itself. And don't forget, if the scan picks up any actionable additional findings, something clinically significant but unrelated to lung cancer.
Like an aortic aneurysm or something else incidental.
Exactly. Then you manage those findings according to the relevant clinical guidelines, just as you normally would.
Okay. Now, beyond the strict medical guidelines, there are also some incredibly important considerations for holistic GP care here, aren't there? Thinking about equity, patient well-being, especially for a program of this national scope.
Definitely. It's vital you ensure equitable access and provide culturally safe approaches for all Australians. Especially consider Aboriginal, Torres Strait Islander peoples, those in rural and remote communities, and people from culturally and linguistically diverse or CALD backgrounds.
And cultural safety is everyone's responsibility.
It is. It's your responsibility as a healthcare provider to deliver culturally safe care. That means acknowledging systemic factors, addressing any personal biases, and related to that, remember the high stigma often linked to both tobacco use and lung cancer. All conversations must be non-judgmental and empathetic.
Yeah, really important.
And finally, be prepared for the psychosocial side. Offer or refer to psychosocial support if needed. Anxiety, and anxiety related to the scan or results or general distress can be a very real experience for patients going through this. As their GP, you're best placed to pick up on that and help.
That program truly highlights the GP's position as a cornerstone of community health, doesn't it?
Yeah.
But